Lung cancer continues to be a growing problem. This year, there will be more people who die of lung cancer than all of the people who are going to die of breast, prostate, and colon cancer combined. Most of that reflects the fact that the average patient of lung cancer is found late stage. One of the challenges to early detection and one of the challenges to finding nodules is now what? Before navigation bronchoscopy, if the patient had a lung lesion, you essentially had three options. You could try a bronchoscopy, but the lung keeps branching, literally like a tree. Once the scope can only go so far, I've got to get all the way out to this periphery. And without direct guidance, you're just like, well, I have no real way to get to this. So you'd either have to put needles through the chest, which work but have a significant amount of complications, or go straight to surgery. There's got to be another way, right? There has to be another way to do it. We've been using the superdimension system, Electromagnetic Navigasyon Bronkoskopisi, for a significant amount of patients. It's a minimally invasive approach, and it lets me get out to the far reaches of the lung. It lets me get to places I could never go with accuracy. Where this lesion is located is in a spot that's well beyond where the bronchoscope can see and where it could go. We're typically planning the case right while anesthesia is getting the patient prepped, because it's 2-3 minutes, if that. You take their CAT scan, and that CAT scan can be used to actually make a 3-dimensional roadmap of you, that I can essentially build out your airways and know exactly where to go to get to your lesion. All right, let's have the superdimension catheter. All right, and now we're going to register. If you look at the navigation screen, what you'll clearly see is virtual and reality merged together. It's almost identical to the GPS in your car, and it's helping to guide me left, right, up, down, etc. Sue, could you bring the fluoro over? Fluoroscopy says we're on top of the tumor. Once you're right in front of it, we'll take out all of the GPS instrumentation, and what has been left behind is something called the extended working channel. That channel has now essentially snaked its way through the lung, parking itself right in front of the mass, ready to now have any instrument you want go down. So I'm going to begin with a 19-gauge needle. Now I'm going to push the needle out into the mass, turn on suction, and back and forth, agitate into the lesion, aspirating out material. You can see the whole mass wiggling. So we'll take multiple different samples. All of my instruments can slide right through their catheter. I can core things out, I can needle them, I can biopsy them, all because we can get out to the periphery. Oh, I got chunks on the end of that one. We'll also sample his lymph nodes. And we'll actually look at the lymph nodes and stage this gentleman. Got a slide for you. So now, because of a digital microscope and on-site pathology, our pathologists are able to make preps right away. With the microscope up, we're able to look at it with them and help to get a sense of quality and whether we're making a diagnosis. Mitotic figures. Plus, what we can do is, if we prove this is a malignancy today, I need to leave markers behind. Well, I can guide a surgeon, leave a little metal clip, put some dye in, something to minimize how much the surgeon has to cut out all in one procedure. And then wake the patient up and send them home an hour later. No cutting. At worst, they have a sore throat. I mean, it's night and day compared to what the other choices were. Electromagnetic navigation bronchoscopy shows up, and suddenly the entire periphery of the lung becomes available to you. Even a minor shift in finding people at stage 1, stage 2, is going to dramatically change the entire structure of lung cancer.
Indicated for displaying images of the tracheobronchial tree to aid the physician in guiding endoscopic tools or catheters in the pulmonary tract and to enable marker placement within soft lung tissue. It does not make a diagnosis and is not an endoscopic tool, not for pediatric use. Flexible bronchoscopy should be performed only when the relative benefits outweigh the risks. Absolute contraindications include, but are not limited to, absence of consent from the patient or his or her representative, unless a medical emergency exists and patient is not competent to give permission. absence of an experienced bronchoscopist to perform or closely and directly supervise the procedure, lack of adequate facilities and personnel to care for such emergencies as cardiopulmonary arrest, pneumothorax, or bleeding, inability to adequately oxygenate the patient during the procedure, pediatric patients. The safety of use of the SuperDimension iLogic in patients with electrically or magnetically activated implanted medical devices has not been evaluated. The SuperDimension iLogic system may only be used by a qualified bronchoscopist, referred to in the manual as the physician, who has read the operating instructions of the user manual and has successfully completed the required training course on how to use the system. Read and understand the entire manual before using the system.